Good morning. Welcome to the Human Services, Finance and Policy Committee. I call this meeting to order. Members, we have a quorum present. With that, I wanted to begin with the approval of minutes. Chair Schomacker.
Thank you, Mr. Chair. I would love to move the minutes from Wednesday, May 15th, 2026.
Chair Schomacker moves the approval of minutes for Tuesday, April 14th.
That's what I said.
2026, exactly. Any discussion? Hearing none, all those in favor, please say aye. Aye. Opposed? The minutes for April 14, 2026 are now approved. Members, we have a long agenda today. We are here to discuss the Program Integrity Omnibus Bill that is before us. And we have another bill which Chair Howard is running a little bit late. So Chair Schomacker, so this is more of an informational hearing. I don't know if you wanted to, you can sit there, you don't have to go there. And so this is more of an informational, so. Okay. With that, I turn over to Chair Schomacker.
Thank you, Mr. Chair. I would move that House File 4338 be in front of us, and we'll move the DE1 to be in front of us for discussion, and would ask Ms. Sunderman to begin a walkthrough of the bill.
I think it's Mr. Berg, yeah.
All right. I would like to ask Mr. Berg instead to begin walking through the bill.
Mr. Chair and members, we'll start with a brief walk through the spreadsheet. You should have in your packet a legal-size spreadsheet like this, which is titled House File 4338 Human Services Omnibus Bill. The House items are in the far right-hand columns that are slightly shaded on your copy. I will just on the first page, I will only note on line 7 at the top that the bill saves a total of $141,636,000 in 26-27 and saves $196,007,000 in the tails. There are totals by agency lower on that page, but I'll skip over those and start on the top of page 2. The first item that's included is a portion of the governor's Transforming Human Services System, OP50. This includes the items related to 3 of the language sections in the governor's miscellaneous article, and you'll see that there are numerous items that are not included in that. One note will come, this item comes with a piece that is at the Department of Children, Families, and Learning, Children, Youth, and Families, that will come to at the bottom of the sheet, and so that one is related to this one. Moving on to page 3, on line 189 is the governor's recommendation for modernizing program payment and payment integrity safeguards. That is in this bill and saves $165.2 million in the first biennium and has a cost of $2.3 million in the tails. Moving down to line 211 is the governor's recommendation for enhancing program integrity and medical assistance. That is in here and has a cost of $24.3 million in 26-27 and $46.6 million in the tails. Moving to page 4 on line 235 is a portion of the governor's item for billing and payment oversight for disability in older adult and behavioral health. It's much of the governor's recommendation. It does, however, on lines 257 and 258, it removes the end of the disproportionate share payments that the governor recommended, which are not in here. There is also a change. We're waiting for some information from DHS because the chairs have agreed to also remove the IRTS costs from there, and that they're still in there on this sheet, but we're waiting for information from DHS to pull them out. Moving on to page 5. Page 6 is the next item. Line 327 is the governor's recommendation on uniform service standards. On line 328, you'll see the general fund cost of $262,000 in 26-27 and $400,000 in 28-29. I'll note this has a state government special revenue fund component below that. It's the only item in the list that has an other than general fund impact. Going to line 340 is the governor's recommendation for earlier effective date for improving supportive housing options. That has a cost of, or a savings of $9.2 million in the first biennium and $1.8 million savings in the tails. Line 345 is a portion of the governor's recommendation on market and receipt-based rate reform for disability and older adult services. The House, the governor does a number of things. The House is only taking the study, which has a cost of $340,000 in 26-27 and nothing in the tails. Moving to page 7 at line 369 is the governor's recommendation on federal compliance for access to services for incarcerated individuals. That has a cost of $178,000 in 26-27 and $3.023 million in the tails. Going down to line 390 is the governor's recommendation for federal compliance with the Medicaid access rule. That has a cost of $1.4 million in 26-27 and $2.268 million in the tails. The next item on page 8 at line 409 is a federal compliance item on household members' background study FBI check compliance, which has a cost of $49,000 in 26-27 and zero in the tails. And then we jump to page, excuse me. Next item is on page 10, which beginning at line 510, these we begin with member bills. At line 510, we have Representative Noor's House File 4638, which is a compliance training language for high-risk providers. That has a cost of $996,000 in 26-27 and $2.186 million in 28 and 29. Moving down to line 520 is Representative Fisher's bill, a portion of Representative Fisher's bill, the 1A amendment on House File 3666. This is the Case Management Working Group. It has a net cost of $374,000 in 26-27 and $374,000 in 28-29. Moving down to line 526 is Representative Hicks, House File 3423, the 1A amendment. It might have been a DE amendment. Anyway, the amended version, which has, this is the MA provider enrollment requirements modifications. They have a cost of $1.612 million in 26-27 and $3.072 million in 28-29. And on the last page, page 11, there is at line 534, Representative Noor's House File 4393, which is, deals with continuity of care planning. It has a cost of $4.574 million in 26-27 and $11.386 million in 28-29. Jumping down to line 549, this is the piece at the Department of Children, Youth, and Families that I mentioned. This is a portion of the larger Transforming Human Services System recommendation. This is also for a study, and it has a cost of $2.247 million in 26-27 and $1.296 million in 28-29. And the final item is on line 11.15, which is funding for the Attorney General's Medicaid Fraud Control Unit. I will note there is an error in the spreadsheet here. It says 1.2 million. It should say 1.23 million. We'll correct that tomorrow. And items not in, I mentioned that we are still waiting to remove the IRTS costs from the 8068 item. We have language in for Representative Noor's MA recipient education language is in the bill. There is not anything on the spreadsheet for that yet because the department has not determined if there's any actual cost there. And then there is House File 4068A1, which deals with the commissioner's authority to impose sanctions. We're still waiting on a fiscal note on that one. And Mr. Chair and members, that's the spreadsheet.
Thank you so much, Mr. Berg. Members, any question, technical question regarding the spreadsheet? Seeing none, we will now move to the discussion on the bill, the articles, and we'll begin with Ms. Sandeman.
Mr. Chair and members, I'm going to do a very high-level walkthrough of the bill. Starting with Article 1, the healthcare article. Sections 1, 3, and 25 through 40 are from House File 4068 as amended in the committee by the A1 amendment. This was Representative Noor's bill reorganizing Section 256B.064, which governs MA sanctions. It also clarifies the applicability of other related statutes, and as amended by the A1, adds sections that allow for administrative review of temporary withholding or reduction of payment actions. The next large batch of sections, we have sections 2, 4, 8 through 10, 12 through 17, 24, and 43 through 46. These all come from House File 3423, the DE1 amendment from Representative Hicks. These sections all make changes to the MA provider enrollment requirements and recodify those requirements. Section 11 is new language. This directs the Commissioner of Human Services to make specified information available to MA enrollees. Section 18 comes from House File 4638 from Representative Noor, which we heard, I think, earlier this week. This is for high-risk MA provider types. It requires the owners who are active in day-to-day management and all managerial and supervisory employees to complete compliance training. It also has a piece in Chapter 245A requiring an attestation regarding third-party assistance with licensing applications and documents. Section 19 is from House File 4491 from Representative Schomacker. This establishes enhanced prepayment review for fee-for-service MA claims. Section 20 is new language, and this establishes post-payment review for MA claims and cost reports and other billings. Sections 21, 22, 23, 42, and 48 and 49 are from House File 4393 from Representative Noor. This is the continuity of care and complex transitions proposal. Moving to Section 41 from House File 4969. This is from the Governor's bill. This allows the Commissioner of Human Services to use the federal remittance advice process as notification when seeking monetary recovery. And finally, Section 47, this is also new language, and it requires managed care plans to conduct prepayment review and publish metrics on program integrity. It also allows the Commissioner of Human Services to recover the full monetary amount of specified claims from managed care plans. That concludes the walkthrough for Article 1. I can move to Article 2. Article 2, just to ground you in where we are in the bill, starts on page 58. This article contains most of House File 4525 as amended, which was part of the larger governor's policy bill. This is the DHS Office of Inspector General policy article, and it includes, it's sections 1 through 38, and it includes most of, like I said, the underlying governor's policy bill. There were a few sections removed on change of ownership processes and sections regarding related individuals, changing the definition of related individuals. So the rest of the article, it's a substantial article, so it modifies background study disqualifications and other background study requirements for certain providers, including, and it also includes federal compliance changes for background studies. It modifies emergency overdose treatment requirements for certain programs, clarifies surety bond requirements. It aligns fraud-related definitions in chapters 245 and 256B. It also modifies and clarifies fraud investigation procedures, payment withholding, and MA prepayment review authority, and makes additional technical and clarifying changes. Moving to Article 3 on page 111 of the bill. All of these sections are from the governor's bill, the governor's budget bill, I should say. And this is much smaller based on some technical assistance from the department. So now the article has 9 sections, and it modifies the National Criminal History, or FBI, background check and fingerprint requirements exceptions. It adds board members and other individuals across different service types who must undergo background studies. It also adds provider types to the prohibition on providing services while background study results are pending, and makes additional technical changes in Chapter 245C. Moving to Article 4, the behavioral health article on page 119. This contains 2 proposals from the governor's budget bill. Sections 1 and sections 6 through 16 are the sections that move up the effective dates that Mr. Berg talked about for recovery residence provisions from January 1st, 2027 to July 1st, 2026. And these are changes we made last year. Sections 2 through 5 and 17 and 18, these establish MA coverage for detained or incarcerated individuals and individuals under conditional release. They also establish the MA benefit for carceral case management services. Article 5 on page 129. This is a substantial article. This is the Uniform Service Standards article, sections 1 through 49. These are all from the governor's budget bill. And what this article does is, in general, transitions certain services that are currently certified rather than separately licensed. Those services are adult rehabilitative mental health services, children's therapeutic services and supports, crisis response services, and certified community behavioral health clinic services. And it transitions them to licensure instead of just certification by the Department of Human Services, and makes various technical and conforming changes related to the move to licensure. And for Articles 6 and 7, I will pass the mic to Ms. Pinelli.
Thank you so much, Ms. Pinelli.
Mr. Chair, members, the next article is Article 6, the Aging and Disability Services article, which begins on page 190 of the DE amendment. This amendment, or this article, largely contains language from House File 4902, the governor's budget bill. The first grouping of sections 1, 21, and 26, establish moratoria on the ICS licenses and setting approvals, and requires an ICS reform study. Sections 2 through 4, 15, 18, 19, and 23 all establish billing limits on certain services and provide for a market rate study for home and community-based services. Sections 5 through 12 and 28 expand electronic visit verification. Sections 13 and 27 address MnChoice's long-term care assessment backlogs and establishes a MnChoice's redesign working group. Section 14 provides role-based access to the MnChoice's support plan system to providers. Sections 16 and 17 modify informed choice in technology provisions. Sections 20 and 22 provide for enhanced staffing documentation in residential support services. And sections 24 and 25 establishes a waiver case management advisory working group, and directs the Commissioner of Human Services to evaluate and report on waiver case management. And that brings us to Article 7, the miscellaneous article. That article begins on page 223 of the DE amendment. Sections 1, 5, 8 through 11, and 13 are all from Representative Norris's bill, House File 2354, which modifies provisions governing MA fraud, provides the Attorney General with subpoena and enforcement authority, and provides for criminal penalties. Sections 2 through 4 and 6 and 7 are from Representative Schumacker's bill, House File 4338, which makes additional parties eligible for cost and fee awards in civil actions and contested cases involving the state. It modifies requirements for assisted living facilities to provide residents with a way to request assistance for health and safety needs. And it adds assisted living facilities to the healthcare facilities exempt from the provider tax. And then finally, Section 12 is from the governor's budget bill that requires the Commissioner of Human Services to conduct a study to assess roles and responsibilities in administering human services programs.
Thank you so much, Ms. Pugnelli. Any technical questions for the nonpartisan staff? Otherwise, we will go back and then maybe they can go back to our first bill that we had on the agenda. Representative Howard? Did he step out? We'll take this bill up and then we'll go back to the discussion. So I move that House File 4207 to be laid over. So please introduce your bill and proceed, Chair Howard.
Thank you, Chair Noor, and to members of the committee, and apologies for being late. On the way over, I was realizing this is, I think, my first time up with the bill, and I don't have treats, and I show up late, which isn't the
I don't know why
great
we
way to
should let you
start,
sit there.
start the day. So, thank you, Chair, for Chair Noor and Chair Schomacker for hearing this bill. This is part of the MHFA policy bill. They are seeking to have Minnesotans with lived experiences help and support in decisions that affect their lives in terms of their grant-making process. They would like to provide a small stipend to those folks, and this legislation would just help ensure that that small stipend doesn't jeopardize their access to other healthcare programs and things like that. So it's a really small, straightforward piece that's modeled after other state programs that have stipends and utilize Minnesotans with lived experiences to help with their grant making and to make sure that what we do at the state government level is informed directly by Minnesotans whose lives will be impacted by it.
Thank you, Chair Howard. Do we have anyone in the public who wants to testify on this bill? Seeing no one, we now move to member discussions. Any discussion on House File 43 at 38? Oops, sorry, 4207. I've got many bills before. Vice Chair Kuhn.
Thank you, Chair. Thank you, Representative Howard, for bringing this. I think that lived experience is actually one of the most valuable tools that we can use, especially, you know, in the human services table, we talk a lot about making sure the end user is a part of the conversation, developing things that are easy to implement, easy to understand, and the lived experience provides us the opportunity to do that. And I think we need to continue to look at lived experience as a really valuable thing. And so thank you for carrying this. Thank you for making sure you're kind of watching all lanes to how this financially impacts their life, because we do need more of them at the table, but we know also sometimes if that income puts them over a level, that then they can't continue to receive the services that they need because they are still in a lived experience situation that they're getting out of, could actually prevent them from bringing their voice to the table. So I think it's a great bill. I support it. Thank you.
Any other member discussion? Seeing none, to your closing remarks, Chair Howard.
Thank you, and thank you for your comments, Vice Chair Keeler. I'm happy to report that MHFA has opened applications and already has several hundred people that have applied, and so this helps ensure that we can sort of see it through. So thank you again, and again, apologies for my tardiness this morning.
We're still waiting for those tweets.
All right.
We'll be here for another hour.
All right.
So with that, I renew my motion that House File 4207 to be laid over, so the bill is laid over.
Thank you.
Thank you, members. We will revert back to our discussion. Any technical question to the nonpartisan staff before we open up for public testimony? All right, now we move to public testimony. The first person on the list is Lance Egley. Please welcome to the committee and introduce yourself and proceed with your testimony via Zoom.
Yes, Honorable Schomacker and Noor and members of the committee. I am Lance Egley, PhD, LADC, LICSW. I'm co-chair of Northern Access Substance Use Provider Network in Bemidji, Minnesota, and of the March lead for systems improvement and paperwork prevention. I'm here to testify by informing elements of the governor's budget with recommendations from a recent DHS report. I comment from the perspective of the DHS report titled Recommendations for Minimizing Regulatory Paperwork and Improving Systems for Substance Use Disorder Programs. Released last fall, this report is not getting the attention that it needs. It's worthy of attention because of its content and good recommendations, because of its relevance to today's programs and policy changes, and because of the 3 legislative sessions devoted to getting it going, and the year of consultation between DHS volunteers, volunteer providers, and 2 national consultant teams in making it. The written testimony has much more scope and detail. For today's hearing, I'm just going to confine myself to the need for consistency and transparency in system building and policy as a basis for program integrity. And by the way, I think this report needs a informational hearing to get enough attention and focus on the details of implementation. The DHS report recommends that the licensing division be more transparent and more consistent in its operations, and that the licensing division review become less punitive and focus more on developing providers' ability to comply. At the end of more than a year of consultation, licensing asserted that it had solved all these problems. In the same month, 85% of the members of the March Public Policy Committee voted to support legislation to make licensing more consistent, demonstrating that licensing needs much more transparency. Providers just don't believe what it says. Evidence from 25 and 26 field experience of providers says that licensing also needs more work on consistency. If lack of consistency leaves providers wondering just what compliance requires, and lack of transparency renders providers unable to ask for clarity and consistency, then no amount of enforcement can produce program integrity. Providers cannot meet requirements that they don't understand. And so the point of this would be that there's a lot of groundwork that needs to be done in communication, in making rules, in clarity, in order to have program integrity work out, and we need to pay attention to that. Thank you.
Thank you so much for your testimony. The next person on the list is Nick Wonka, Director of Medicaid Fraud Control Unit. Welcome to the committee. Please introduce yourself and proceed with your testimony.
Good morning. I'm Nick Wonka. I'm the director of the Medicaid Fraud Unit. And thank you to all members of this committee for including us in this program integrity package. As I've testified previously, true program integrity necessitates protections on the front end by preventing bad actors from enrolling as providers. It requires oversight of enrolled providers, and it mandates investigations and prosecutions of fraudsters who still manage to sneak into the program and once they're in, choose to steal. With this bill, you're taking impressive measures to protect program integrity through closing gaps in the enrollment and screening process and ensuring better oversight for enrolled providers, while still making sure these programs work for people who provide the services and whose lives depend on receiving them. And thank you for incorporating the MAP Act's policy language, recognizing our role on the back end and the need to ensure that anyone who enrolls as a provider and chooses to steal knows that we as a state have the tools and resources to find those fraudsters and hold them accountable. With this language, we'll be able to do that as a state, just as the people rightfully demand we do. But I do want to emphasize one thing. The appropriation you have in here is for 1 year. 1 year of funding for us to expand from 32 to 50 people, but nothing after that. To ensure an ongoing, robust investigative effort, the money for the Medicaid fraud work needs to be an ongoing appropriation, not funded, for example, out of Medicaid recoveries or some kind of other funding mechanism. Minnesota law right now requires that payments from fraudsters go to the victims of crimes, which they do in our cases. Our recoveries go back to the crime victims, which here are DHS, managed care organizations, healthcare agencies whose employees defraud them, or individual crime victims. None of it goes to the Attorney General's office. And there's good reason that none of the recovery money goes back to the Attorney General's office. State law doesn't allow it. And we also don't want prosecutors' offices incentivized into accepting plea deals because a defendant can write a big check that would cover their salaries. We don't have or want a justice system that allows fraudsters to buy their way out of accountability. We want a system that gets accountability and justice based on the facts and the law, and not on a fraudster's ability to pay a prosecutor's operating costs. Funding the Medicaid fraud unit through an ongoing appropriation is the best way to maintain that justice system. We ask you do that, and we thank you for your support.
Thank you so much for your testimony. The next person on the list is Philip Odonis. Please come to the testify table, introduce yourself, and proceed with your testimony.
Thank you, Chairman Knorr, and Nick, and everyone who's been a part of trying to continue to improve social services in Minnesota. My name is Philip Odonis. I work in a IRTS setting, and those are residential mental health treatment programs, which often serve people coming out of the hospital, out from behavioral health, sometimes other settings, like chemical dependency treatment. And I think I speak for a lot of us in the field. You know, we have family who are affected by mental health issues. We may be ourselves. I have a quote in my office from George Carlin that I like. It says, just because you got the monkey off of your back doesn't mean the circus has left town. So I know right now this committee is trying to help clean up the circus a little bit. That's appreciated. I'm here to speak to proposed policy changes with intentions that I think are very positive, but I wanted to just point out some perspectives from, less from myself, but from some of my colleagues. We had a conversation yesterday about some of these, specifically the proposal to change the pre-approved IRTS length of stay from 90 days to 30 days. And when I brought that up, some of my colleagues, we had a great conversation, and I felt like it could be a wonderful window into what's actually going on in these programs, a view from, you know, kind of from the ground instead of the hill. And prepared kind of did something a little unique. I recorded the conversation, and with their permission, of course, and we created a little AI summary. So you're getting, everything is just coming out of that conversation, and I encourage you to read it, if not now, later, because I know all these policy and programming proposals are going to be continuing to move forward over the next year. I think it provides really important insight, particularly into some of the reasons why a 90-day stay at an IRTS program is oftentimes essential for people. And we just encourage thoughtfulness as changes are considered around that. Thank you for your time. And I have more copies if anyone doesn't have one, but I think it made it into the folders.
Thank you so much for your testimony. The next person is Aaron Jacket. Welcome to the committee. Please introduce yourself and proceed. I just wanted to note that the 30 days limit was already removed from the DE.
Good morning. My name is Aaron Jacquard. I am a certified peer support specialist at a Minneapolis-based IRTS facility. I'm here to speak specifically to language around reducing the pre-approved IRTS stay from 90 to 30 days. Today, while my path is focused on helping other people who are struggling find a way to move forward, but it was not always this way. Like many of the clients I now serve, I once felt completely alone, overwhelmed by anxiety and depression, and disconnected from the world around me. Years of battling mental health challenges had left me worn down, hopeless, and searching for a way out. In a moment of desperation, I reached out to cope and found my way at the IRTS facility in Minneapolis. The first 10 days of the facility I was simply exhausted and overwhelmed by all the things that had happened. It took me about a week and a half just to get out of bed and find myself able to trust the people around me and begin the healing process. It took an additional 5 days before I started opening up to my counselor and making plans to move forward. And even more time to get back on the proper medication regime and see the doctors and professionals that would help me on my journey. There are groups, one-on-one counseling, endless amounts of forums that I'm sure many of you are aware of. Legal matters, clients face a lot of challenges, and I face those too. This story is repeated every day at my work at the IRTS facility. I see people on the exact same journey. It's a profound and important one, and one that cannot be squeezed into 30 days. Clients are at these facilities for 90 days. It is not an arbitrary number. It is a realistic expectation of the time it takes people to stand back up after falling so far. Today, I stand on the other side of that experience as an employee at the very place that once welcomed me when I needed it most. The transformation didn't happen overnight. It came from showing up every day, doing the work, and making a conscious decision to build a better future for myself. Thank you very much.
Thank you so much for your testimony. I just wanted to note that the 30-day is not in the DE that we're looking into, just to confirm that. The next person on the list is Dr. Eric Larson. Welcome to the committee. Please introduce yourself and proceed with your testimony.
Good morning, Mr. Chair and members of the committee. I'm Dr. Eric Larson. I provide EIDBI services to young children with autism in their homes and community. And I also am the chair of the Autism Treatment Association of Minnesota. I'm speaking today to urge you to deliberate further on the proposed EIDBI billing limits that are line in page 209, I believe, of the amendment. Excuse me. The reason that I'm asking to delay deliberation is because the EIDBI statute is already a long, complex law with many pages of accompanying regulations in the DHS MHCP manual. It was passed back in 2013 after 5 years of advocacy and followed by 5 more years of extensive formal public input, task force, and work group meetings with many in the public involved before large numbers of children were even able to access this treatment. In the statute, 2 additional ongoing advisory committees are specified. It provides for a high level of safeguards against fraud and, equally important, for a high level of effective treatment. It's a leading example of intensive early intervention in the country. However, the limits offered today were first presented to us 1 week ago with no opportunity for public input or scrutiny. They therefore come with a risk of unanticipated repercussions that can both create the risk of fraud and harm effectiveness. Instead of utilizing these new limits, the DHS already requires an extensive sequence of oversight. First, each child must be found to have a qualifying diagnosis for medical assistance by the state medical review team. Then, a comprehensive multidisciplinary evaluation is completed by a licensed professional who writes a 20-page recommendation for the specific treatment hours of EIDBI and must have that approved by the DHS authorization agent. Once that evaluation is approved by the DHS authorization agent, then a QSP writes an additional 20-page ITP, individualized treatment plan, for the specific billing codes being considered today and must have that approved by the DHS authorization agent. This cycle's repeated every 6 months, and frequently the DHS authorization agent will deny the level of hours being requested. Then the provider has the opportunity to appeal that denial and may succeed in modifying the approval. This entire process was explicitly designed to ensure that the most cost-effective services are received by each individual child. The resulting pattern of billing codes for the individual child is transparent to the authorization agent and to the DHS auditor, and thus also enables the detection of fraudulent patterns. However, if the full level of necessary supervisory hours become limited by this bill, the costs will become absorbed into the provider's overhead and become less detectable to an analysis of fraud. Worse, when a provider obeys the limits instead of absorbing the costs, the most challenging children receive less service than is necessary to effectively treat them. The evidence shows that the most challenging children are at heightened risk of death from bolting into traffic or drowning, and also may end up boarded in emergency rooms when their parents cannot keep up with their demands. Further, the most challenging children often suffer from frequent staff turnover, and the new staff require extensive ongoing supervision on the job in order to acquire the sophisticated skills that result in cost-effective services. In summary, EIDBI providers are already subject to regular authorization of treatment requests and are eagerly participating in the development of the new program integrity provisions. However, by putting a brick wall in the way of services to the most challenging children, the state does not surveil for fraud, but does instead create the risk of high long-term costs for those most challenging children. Thank you.
Thank you so much for your testimony. The next person is Josh Berg. Welcome to the committee. Please introduce yourself and proceed.
Thank you, Mr. Chair and members, and thank you for the opportunity to be here again today. I want to begin by expressing genuine appreciation for the bipartisan effort this committee has shown throughout session. Watching the evolution of this committee has been encouraging, and I commend you for tackling complex issues with seriousness and at times some much-needed lightheartedness, and for the most part, without sliding into partisan bickering. That restraint matters, especially when the focus stays where it belongs, on the individuals receiving supports and services. Human services is not bipartisan. Caring is not a partisan issue. Caring for our fellow Minnesotans is not partisan. And when this committee centers on people rather than politics, it shows. As we move into the later stages of session, I want to urge you to keep several core principles front and center. First and foremost, continuity of care matters, always. Every policy choice in this space creates ripple effects that land squarely on real people's lives, and those consequences cannot be an afterthought. Caps on services, moratoria, and artificially constructed criteria do not change the underlying needs of individuals with disabilities. Lives do not pause or become more convenient because policy has shifted. What these policies do change is access. They increase barriers, erode person-centeredness, and weaken preventative, cost-effective supports. When barriers are raised under the guise of program integrity, individuals are left with two outcomes. Either their needs are met in more expensive, less person-centered settings, or they are not met at all, increasing the risk of hospitalization, declining health, or reduced quality of life. That is not integrity. That is cost-shifting and human harm. Your challenge and responsibility is to strike the right balance between accountability and safeguarding public dollars, while also protecting and improving quality and stability of services. That balance is difficult, but it is achievable when stakeholder input is taken seriously and decisions are made with humility about what policies actually look like on the ground. And I want to say this plainly. While DHS is doing difficult work under real constraints, many of the crises we are now responding to are the product of decisions made in isolation. Without meaningful stakeholder engagement, without sufficient transparency, and without a clear understanding of the people the system exists to serve. Consultation cannot be an afterthought. Engagement cannot be performative. Absent deep and sustained stakeholder involvement, bias, often unintentional, inevitably finds its way into policy design and implementation. That is why your role is to provide oversight, direction, and accountability, and is critically important. Finally, a brief word on the ICS reform study provision. Thank you for choosing a path that does not dismantle the core intent and functionality of ICS. Do I wish the legislature were more clearly in the driver's seat? Yes. Do I wish the process were more objective and transparent from the outset? Absolutely. And yes, I think we could have pushed harder in some areas and believe that the proposal could go farther and faster. My concern is this: if this work is led primarily by those who designed or administered prior policy decisions without robust, authentic stakeholder engagement, there's a real risk that existing assumptions are reinforced rather than challenged. Studies that are not co-created almost always reflect institutional perspective more than lived experience. But I also know this: when no one walks away fully satisfied, it usually means we've landed somewhere workable. That's a starting point, not an ending. I will stay engaged, and I know many others in this room and outside this room will too, to ensure that we build the best version of ICS possible. The people we support are counting on us to get this right, and I, for one, will not let them down. Thank you, Mr. Chair, Chair Schomacker, and committee members. It has truly been an honor working with you throughout this session.
Thank you for your testimony. The next person on the list is Jay O'Neill. Welcome to the committee. Please introduce yourself and proceed with your testimony.
Good morning. Thank you, Chair Knorr and committee members. My name is Jay O'Neill, and I am representing the Autism Treatment Association of Minnesota, and I'm president of Behavioral Dimensions, an agency that provides in-home EIDBI services. I'm testifying about concerns related to proposed building limitations. I want to address the fact that the state already has a system in place to ensure appropriate utilization of services. As Dr. Larson referred to before, EIDBI units are individually authorized based on each child's unique needs as assessed and recommended by licensed professionals. This existing authorization process provides oversight, ensures medical necessity, and allows for individualized care planning. Picture a young child, if you would, a young child with autism, maybe 3 or 4 years old, who is just beginning to learn how to speak and communicate. Maybe they do not have words yet. Maybe they engage in behaviors that put their safety at risk. They may not be sleeping well at night. They may be very challenging to toilet train. It may not be possible to easily take them into the community. There may be incredible stressors in the family leading to marital challenges. For that child, early intensive and individualized intervention can and has changed the entire trajectory of the family's lives. I have personally spent thousands of hours in families' homes who have received these early intensive intervention services. The trajectory of their lives has been impacted beyond belief. Kids who need constant supervision now function independently and successfully in schools, workplaces, and are contributors to society. That is exactly what EIDBI is doing and was designed to do. Placing caps on services may prevent some children from ever reaching their full potential. Providers will be limited in the services they can provide, and in many cases, the children needing the most support will not be served and will cost families untold stress and the state incredible financial costs. If proposed caps are implemented, the ability to adjust care as children grow and develop might be limited. Quality and safety of that care is reduced. Access may be cut off entirely for families in rural and underserved communities. We urge you to protect the integrity of EIDBI and preserve the ability to provide truly individualized care. Because for these children, this is not just about services, it's about their future. Thank you for your time and consideration.
Thank you so much for your testimony. The next person is Ellie Skelton. Welcome to the committee. Please introduce yourself and proceed with your testimony.
Good morning, Chair Knorr and committee. Thank you. Good morning. Ellie Skelton, Executive Director at Touchstone Mental Health. I'm also the current president of the Mental Health Provider Association of Minnesota. I echo Josh's words. I really appreciate all the work you've done this session. It hasn't been easy. Even watching on YouTube, it's like, oh, thank you for being here and doing this work every day. I really do appreciate it. I have I also want to thank you for taking out the 30-day IRTS limit. You know, there's so much paperwork and so much acuity, and I know those individuals didn't quite understand that it had been taken out of this, so appreciate that. I do have 3 concerns: the surety bond, the financial capacity, and then wanted to just talk briefly about ICS. So the financial capacity, on 2312, it says a provider must demonstrate financial capacity as described at revalidation. I understand the intent of that is that when we had a provider with hold, there were a lot of folks that couldn't make payroll and vulnerable adults were hurt. If we move forward with this, even more vulnerable adults will be hurt. I think there's a lot of small providers that aren't really plugged in. They're doing home care, they're doing good work. They're gonna get to revalidation if this passes a year from now, and they're gonna say, you need to have 90 days, and it's very broad language. 90 days that for repayment, for payroll, and they're not gonna have it, and they're gonna shut their doors. They're not gonna get revalidated, or it'll be kicked down, and you know what's gonna happen? They're not gonna be able to serve those vulnerable adults, and they're gonna lay off those staff. It's like kind of a catch-22. What you're trying to prevent could actually exponentially happen more. I would really urge you to reach out to people in your area and say, any behavioral health providers in do they have 90 days of cash right now? Would they be able to meet this? You know, we just bought a building from a line a couple years ago. We were kind of forced to because we'd either have to relocate or buy this building, went back and forth, back and forth. We went and got the smallest mortgage we could because of the interest rates. So that really pulled down our cash. You know, would we have to take out a bigger mortgage so we'd have the cash and pay more in interest? And then I couldn't provide that. All the money we have extra, we give to staff. Every year, if I have any extra money, whatever my board will let me, we give them incentives. So any money that I have to pay interest for a surety bond, giving money away to an insurance company for no good reason, you know, we're an established provider. We're gonna do the best we can. I have 28 days of cash right now because UCare owes me $450,000 for services provided last year. I've got some assurances, maybe they'll pay us this summer. Like my CFO has a heart attack every other day. I'm like, the money will come. Don't worry, the money will come. So With that said, the one last thing I want to talk about is on page 214, the exception process. So we've been working on a project with Aon to open up 72 units of housing right next to St. Olaf Church is really involved. It's going to be a great project. We've been working on it since 2017. To make it work, it needs to be an ICS. I would love if you could just add in here in the exception process, projects working with Minnesota Housing with the goal of ending long-term homelessness. We just had an opening yesterday of a project with Kyle Garden Square, 59 units, 48 people coming from homelessness. A quarter of that building is ICS. That is 20% of our funding. 20% of our funding in that building comes from HUD, COC, that's at risk. So we can't afford, and that project doesn't even break even. Most of our supportive housing doesn't. We come close. We fundraise. So I just would really want to make sure that we can get across the finish line with opening up Exodus for those 72 folks that are, many of them sleeping in their car or in a homeless shelter right now. And we desperately need that ICS funding to open up that building. So thank you for hearing me and appreciate your time and attention today.
Thank you so much for your testimony. The next person on the list is Jennifer Diedrich. Welcome to the committee. Please introduce yourself and proceed.
Thank you so much, Chair and members of the committee. My name is Jen Diedrich. I'm the Chief Compliance Officer at MAC Midwest, formerly Minnesota Autism Center. We're a nonprofit provider. We serve Minnesota families for 30 years. This is our 30th year. I also represent the Autism Treatment Association of Minnesota and providers who deliver the critical EIDBI services across our state. Let me be direct. We absolutely support program integrity, but this proposal as written will destabilize the provider system and reduce access to care. I want to make 2 quick points as to why these requirements risk reducing access and not assist in preventing fraud. Point number 1, the bill in regards to surety bonds requires providers, particularly those designated as high risk, to carry a surety bond of at least $100,000 or 10% of annual Medicaid revenue, whichever is greater, and to demonstrate 90 days of financial capacity. In the current environment, that's not a safeguard, it's a barrier to survival. Providers are already operating under intense financial pressure. Ongoing audits, prepayment review, and payment deliveries have created a system where cash flow is unpredictable at best. Many providers are carrying large receivable balances and experiencing delayed reimbursements through no fault of their own. At MAC, just to share a little bit about us, we currently have approximately $3 million in Medicaid receivables, with nearly half aged beyond 30 days. We're also owed nearly $800,000 from UCare, with no clear timeline for recovery. And again, this is not unique to us, as we just heard, this is systemic. Against this backdrop, requiring providers to secure additional capital through surety bonds and maintain 90 days of reserves is not realistic, and it's not attainable for most nonprofits and community-based providers. Point number 2, these requirements will not target bad actors. They will eliminate compliant providers who lack access to private equity or large capital reserves. In effect, this proposal reshapes the provider landscape to favor well-capitalized organizations while pushing out smaller, high-quality providers who have served Minnesota communities for decades. We've already seen how difficult it is to access capital. For us, when prepayment review was implemented, MAC approached 5 traditional banks and we were denied. We ultimately secured a line of credit through a non-traditional lender with significant fees. Adding a surety bond requirement on top of that is not feasible. For many providers, it will be the tipping point. If the legislation's intent is to ensure financial stability, there are more effective approaches. For example, strengthening the long-term services and support loan fund would provide a pathway for providers to responsibly meet financial expectations without forcing closures. The bottom line is this: Article 1, Section 12, page 21. If enacted as written, these provisions will reduce provider capacity, limit access to EIDBI services and other services, and disrupt care for Minnesota children and families. We urge you to reconsider these requirements and work with providers on solutions that protect both program integrity and access to care. Please help us stay in business serving the Minnesota children, young adults, and families for another 30 years. Thank you.
Thank you so much for your testimony. The next person on the list is Brian Zerbis. Brian? Oh, it's on there. Welcome to the committee. Please introduce yourself and proceed with your testimony.
Thank you, Mr. Chair and committee members. My name is Brian Zerbis. I'm the Executive Director of March at Statewide Trade Association for Subsidy Store Programs and Professionals. I also like to applaud the efforts that this committee is taking towards improving program integrity and oversight, but we also want to ensure that the actions have the desired effect. There's three parts I'd like to touch on. One is in Article 3, Section 5, regarding peer recovery support services and background studies. Peer recovery support is built on lived experience, and part of that lived experience for people includes justice involvement. We have concerns that the disqualifications may have an impact on current employees. We asked for a delay to give time to evaluate the impact on the current workforce of this change. Alternatively, this committee could consider increasing funding to organizations, specifically that employ peers that are unable to pass background studies. The next, in Article 4, in the behavioral health section, sections 1 and then 6 through 15 is the piece that would seek to eliminate freestanding room and board 6 months ahead of the planned elimination. And then also to move up the recovery residence work group and changes recommendations by a year and move up the certification to this July 2026. Last session, all of these changes were just passed. There was a recovery residence work group that was created and convened. They've met for a few months. To my understanding, they've not brought forth or solidified recommendations to make these changes. We would I'd also like to point out there has been significant upheaval in the recovery housing in the last few years, and we would ask that the recommendations from the work group, or for a pause to have the recommendations from the work group be finalized and then move forward with those recommendations from that work group. The last piece is in Article 6, Section 6, electronic visit verification. Specifically, line 201.8 notes that all unit-based services delivered by a provider deemed high risk. I would like to point out that 245G programs have non-residential services that are unit-based billing. Those programs may provide peer recovery support services. They're not required to, but when they do, it would seem that this language would also require them to do EVV for all unit-based services, which would include groups, counseling, assessments. And if you think of a small program, they may have hundreds of codes in a week that they bill. Larger non-residential programs may have thousands of codes that they're billing for. So we just want to ensure that the focus of this language is really looking at the high-risk service, peer recovery support, and not the high-risk provider type. So the recommendation would be to have all unit-based services designated high risk by the commissioner, et cetera, be eligible for EVV. Thank you.
Thank you so much for your testimony. The last person on the list is Crystal Zaviska. Hopefully I said your last name correctly. Welcome to the committee. Please introduce yourself and proceed.
Good morning, Chair Knorr and members of the committee. My name is Crystal Zaviska. I'm the Financial Assistance Manager with Western Prairie Human Services, servicing Pope, Grant, and Traverse counties. Today, I'm here to speak with you on behalf of MACSA, Minnesota Associations for County Social Services Administrators. I love when you nod and acknowledge the acronym. And also on behalf of the Minnesota Rural County Association. So the first thing I would like to point out is the letter you received kind of highlights a lot of things that have been testified again about in the past. But one recent thing that has come to our attention in this session that we want to raise awareness to is in 2025, legislation was passed that would establish a uniform non-emergency medical transportation program, NEMT, for all medical assistance enrollees. DHS was directed to contract with a vendor to manage this statewide program. Due to recent cancellations of the RFP for the centralized provider, counties need your help. Current statute 256B.065 subdivision 18I was changed to have a centralized provider be the administrator of this program. Ending the legal authority for counties to continue to administer NEMT after 7/1/2025. Counties are asking for you to consider postponing this enrollment or give us some guidance on what to do. Current statute is putting us in a position where we are not going to be able to support our enrollees accessing the refunds and reimbursements to get to their medical appointments. And with the RFP being canceled, we have 3 months to get this figured out. So we would like some guidance and maybe consider postponing that part of the centralized provider. That's the hot topic. In addition to House File 4338, counties would like to talk about transforming human services, and transforming our human services delivery system is a key element of House File 4338, and counties are committed partners in this conversation. We support a comprehensive study of the roles and responsibilities of the counties, tribes, and the state, a robust working group to examine our system, provided that direction to the working group does not presuppose conclusions. Continuity of care. Counties appreciate the recognition of the state-county partnership when individuals are affected by disruptions in our provider community, no matter what the cause. We would like more clarity in lines 33.13 through 33.17 that describes lead agency duties. Unfortunately, when our residents are affected by provider disruption, it is incredibly difficult to find alternative placements. Counties would like to work with you to understand the process and financial impacts for this proposal. We appreciate the direction of the Department of Human Services to assist counties in conducting long-term care assessments using certified assessors. We look forward to partnering with DHS to determine the appropriate conditions in which these assessors are deployed. Counties have been working with the Department of Human Services to address current backlogs and stand ready to participate in another work group to discuss ongoing challenges and potential redesign of MIN choices. Long-term care services and supports. We appreciate the inclusion of several items that counties and others have been discussing as a part of our work to find savings in our long-term services and supports, the LTSS area, in advance of proposed significant cost shifts. As you consider these reforms, we strongly urge the legislature to include language so that any savings be attributed to the cost shift target. Chair Knorr and Chair Schomacker, we appreciate that this proposal does not include additional cost shifts to counties, particularly considering uncertainty related to the implementation of federal reforms and looming cost shifts authorized by the legislature in 2025. We recognize that you and your colleagues have great challenges before you in addition to the priorities outlined here. We also want to underline the significant staffing and technology pressures on the counties as we implement the federal legislation, H.R. 1, and support program integrity. Conversations around many of these items are occurring in other legislative committees, but we want to highlight the importance of investments in staffing and technology to support our work to ensure that our system puts the needs of Minnesota individuals and families first. Please consider us a resource as you assemble your final proposals.
Thank you so much. And definitely we'll continue having the stakeholder conversation as we proceed with the bill, so there's much work to be done. Appreciate everyone who registered to testify, and I just wanted to ask if there's anyone in the public who wanted to testify on the discussion of the DE1. Not seeing anybody else. With that, any technical member questions for the testifiers? Representative Hicks.
Thank you, Chair. I would like Dr. Larson or any of the EIDBI providers I'd like to ask some questions about how we're currently billing ITP to planning and development.
Representative Hicks.
Thank you. And I want to start by saying, Dr. Larson, I appreciate the services you and your colleagues provide to kids. I firmly believe that my child is as successful as he is because of early interventions. Deep in my heart, one of the most important things that I see as my role as a legislator is to protect this program, because I really do not believe that my child would be where he is without services. So I want to kind of lay that groundwork. But I am frustrated that any kind of guardrails around limits is responded to as if it is somehow an attack on children. And so I just want to, you gave wonderful explanation about all of the safety guards that are in place for EIDBI, which I really appreciate. But I have a question. Is H0032, treatment planning, is that in the service authorization, and do you need authorization for it?
No, that's.
Dr. Larson.
Oh, sorry. Yes, Representative Hicks, that's not listed as one of the authorization requirements.
So currently,
Representative Hicks.
thank you. So currently, are you able to bill that code with no guardrails or oversight, no caps of any kind? Is that currently correct?
Dr. Larson.
Yes, I agree, that's correct.
Okay.
Representative Hicks.
Dr. Larson, how is that code billed? Is it a 15-minute unit? Is it an hour? Is it an encounter? How is that code billed?
Dr. Larson.
Representative Hicks, it's billed as an encounter.
And
Representative Hicks.
for my colleagues, an encounter means they can bill it for 5 minutes or 5 hours. As long as they provide the service, they bill the encounter. For my colleagues who are maybe not so hyped up on medical billing.
Dr. Larson.
Dr. Larson, who can bill that code?
The EIDBI providers.
Which levels?
Representative Hicks.
Which levels of providers?
Dr. Larson.
Representative Hicks, it's the EIDBI, QSP, or level 1 or level 2 providers can bill those codes.
Representative Hicks.
Dr. Larson, what is the rate that a level 1, so someone who's in graduate school, bills for that code?
Dr. Larson.
Representative Hicks, I do not have the billing grid in front of me.
Representative Hicks.
It's $94.80, or almost $29,000 a year at 300 units a year, which is the limit in this bill. Is ITP programming and development a direct service with a child, or can it be billed without the child or parent present?
Dr. Larson.
Representative Hicks, it's designed to be billed for either mode.
Representative Hicks.
Thank you. So I just want to be clear. We are putting a limit on a one billing code that currently has no limit, and we are saying $28,000 a year to update the treatment plan is enough. We have to put some guardrails on, and saying that any kind of limit is an attack on children and the quality of service is disingenuous, in my opinion. I am open to a conversation about adding some language that if there is a true medical necessity, that there is a prior authorization that can occur to ensure that that is taken care of. But the idea that there is absolutely no cap, no limit, 4 people can bill it $94.80 every day and say they're updating the treatment plan is irresponsible. And I am hopeful that this legislature will take a real look at both what benefits children and what protects Medicaid funding.
Any comments, Dr. Larson?
Yeah, in our program, we review Mr. Chair, members of the committee, in our program, we review the child's treatment plan on a weekly basis. We have a treatment plan review meeting that the EIDBI, QSP, and the level 1 and level 2 professionals revise the treatment plan based upon the data collected that week, present that to the entire team. So our treatment team has anywhere from 3 to 6 members on the team who attend this treatment plan meeting with or without the child present, but typically with the parents present. And that treatment plan meeting generally lasts an hour and a half each week. Each of the treatment plan team members are then collecting that data on a daily basis, and it's summarized generally by the level 1 or the level 2 professional, the data each week, again, in preparation for the treatment plan meeting that is conducted that week. And because of that process, the program's very customized to the individual needs of each child, and it's the most cost-effective. A child that doesn't require high one-to-one hours, because the data is showing how effective the current level of hours is, does not require increases in hours. And the child who's showing stress in their programming, the programming's adjusted to meet their needs, and it's done on a weekly basis. If we were in our early intervention program, if we were only reviewing the treatment plan once every 6 months, which is the minimum standard for EIDBI, we would not be making the timely adjustments to the treatment plan that are necessary in order to be maximally effective for the child. Therefore, each program that we serve, the children may last in treatment from 1 year to 6 years, with an average of about 3 years, without the timely treatment planning that goes on to maximize the effectiveness and minimize the stress on the child. The services can be indefinite in length.
Well, thank you so much, Dr. Lassen. Do we have anyone else with questions for Dr. Lassen? Just wanted to review that section 15. I think if you look at the intensive services for 40 hours limit, is that something that is doable per recipient? Because we're capping at 40 hours, and then also the travel for 2 hours per day per recipient. Are those basic numbers that can be done, or are those also extreme when we look at the services that you provide?
Mr. Chair, our average number of hours of services per child is about 26 hours a week. Some of our children are receiving less than 10 hours a week of one-to-one services, and others are receiving more than 40 hours a week. So as I had said earlier, the needs of the most extremely challenging children are daily and more than 8 hours a day in order to manage the risks to their health that come from their self-injurious behavior, their eloping in the community with risks of drowning. Those children with high needs, they're either not going to receive the safe treatment that they need, or their services are going to be indefinite. And we've seen over the course of the past 50 years in the state of Minnesota that when inadequate supervision and intensive services are delivered to some of our most needy children, they end up institutionalized for their lifetimes at extremely high costs. So we are not advocating that every child get 40 hours a week of treatment. We're advocating that the hours are customized for each child so that they're getting the right level of services rather than too much or too little.
Vice Chair Gilman. Representative Gander.
Thank you, Mr. Chair. Just for clarification, if we have the plan review meeting attended by 3 to 6 members pertaining to, say, one child, would each of those 3 to 6 members bill that code for that child for that week? Or would it be billed only once for that child for that week?
Dr. Lassen, I don't want to put you on the hot seat, but you're on the hot seat today. Go ahead.
Yes, thank you, Chair Knorr, and Representative Gander, that would be for each one of those service providers, their billing for their services to the child's team.
Thank you, Mr. Chair. Just for clarification.
Any other member question? Seeing none, we'll move to other questions for other testifiers. I have Vice Chair Gilman. Who did you want to come to the testify table?
Thank you, Chair. I would love to have March come back up, Brian Zervis. And then also, just curious if the department could also come up, if there's anybody here with the department that might be able to answer some questions as well. Thank you for your testimony, Brian. So you mentioned 3 different articles that you've got concerns with. Yesterday in another committee, I'll just give a little background. When we invest in working groups and studies and we're trying to gather information as a committee, I get so frustrated that we don't wait for the information. So I appreciate that you're bringing that forward. That we don't even have the working group's response. So I'm just curious if this is coming from DHS, this proposal to not wait for the working group's information. When is that due? So I'm not sure who I should talk to about that.
I think the reference is page 128, line 128.16, which was due on or before January 1, 2027. That changed to 2026. Director Graham, did you want to respond to that?
Mr. Chair, Representative Gilman, I'm sorry, you're referring to the requirement that you all passed last session about the working group and the recommendations and where that is? Is that what you're asking?
That's what I assumed. Is that the question? Yes.
Okay. Mr. Chair, Representative Gilman, I know, as Mr. Zerbis mentioned, that working group is getting going, and I think Chair Knorr, you just described what the date was that it's due, but we're happy to get that. I think I'd have to look at the law to double check when it's due, but I know that they've been actively meeting and discussing this issue.
Vice Chair Gilman.
So thank you, Chair. So I would just love to have Mr. Zerbis go into a little bit more detail on why the dates would be a conflict, for the work you're doing.
Mr. Zerbis.
Mr. Chair, Representative Gilman, so I think part of the concern with the dates being moved up, this work group was established last session. As Ed mentioned, people were appointed to the work group as voting members, and they represent people in recovery, sober housing, or recovery residents, vendors, DHS staff, things like that. It's also open to the public, so anyone can attend these meetings, kind of see what's going on. And I think, as you mentioned, the idea with this work group is to pull together experts from kind of different parts of that industry to figure out what changes need to happen, how can we make recovery residences eligible for, or to be certified, to have all these other requirements that were passed last year, and then also to be eligible for housing supports payment in the higher levels. So the idea of kind of bypassing or kind of overstepping the work of this work group to kind of bring forth recommendations ahead of time doesn't seem well advised, and it kind of undermines the work of a work group to look at the problem, be thoughtful, and then bring recommendations to this body in 2027 to then take action at that point.
Thank you.
Question, Gilman.
Thank you, Chair. And then, so my question then is for you, Ms. Grom. Why is this happening? Why is this a recommendation? That we would not wait for that, so we could, take action on that.
Director Graham.
Chair Knorr and Representative Gilman, we very much respect the working group process, and the working group process and recommendations are not limited to just this issue. They are much broader. As you know, last session we discussed issues around local governments having restrictive ordinances for recovery residents housing. There's a lot of issues that need to be discussed and addressed, and there is still ample opportunity for that work group to make those recommendations. This particular change is being made, and we have discussed it with some, with our external partners. It's being recommended because there has been an exponential increase in freestanding room and board spending. And that was part of the reform, was to try to control the unregulated use of freestanding room and board, and instead shift that to make sure that people are using supportive housing or housing support option instead, in a way that we can regulate and make sure that spending isn't going unchecked. So we had flagged this as a program integrity issue in the department, that we had seen just this influx in spending, and we talked with community and determined that we were able to implement the certification sooner. It's a voluntary certification, and that we were also able to implement the housing support option sooner. So last session, the legislature allowed recovery residences to work with the agency directly to get housing support funding as of January 1, 2027. And this proposal will allow that to occur July 1, 2026, in line with the new phase out of freestanding room and board. I hope that's helpful and addresses your questions, Representative Gilman. Happy to share
Vice Chair
more.
Gilman.
Thank you, Chair. I would love just at some point to have just more, we can have some more offline conversations around this. I just get concerned when we take and we establish a working group and we want to have just thoughtful conversations. We've met other times and we've done some really great work around this bipartisanly as well. And so I appreciate that you are looking at, program integrity and trying to put guardrails around taxpayer dollars. That's absolutely something that we want to see happen. I also would love to see, before we, move dates and times and we don't get the information back, I just want to know how we can, in the interim, respond or get things ready for next year, when some of these supports and things would be then detrimental to the health and well-being of those folks that are receiving the services. So I'd love to visit more. We'll probably be talking more about this. I do want to go really quick to peer recovery support services, Article 3, Section 5. You did talk about that a bit more too. You talk about delaying implementation for this requirement. Tell me more about the folks that are doing the work and why you're concerned about this also changing.
Vice Chair Gilman,
thank you.
are we talking about the page 114, line 114.7, the providers of peer recovery support services, or is it a different
Yes,
section?
Chair, yep.
Mr. Zarvis, I think you can give us the context of that.
Yeah, thank you, Mr. Chair, Vice Chair Gilman. I know there are recovery community organizations that were preparing a letter to respond to this part as well, and weren't able to get in time. I think part of the concern with recovery community organizations is they are currently employing people that wouldn't pass a background study, and they do those through other grant funds and things like that. So that I would say the primary concern for them is if this were to come to pass, they would have current employees that are currently doing the work, that are successful working with, for example, other justice-involved individuals that, they can speak with those clients better than I could. Because, I don't have that lived experience. So I think that's part of the thought of, if it can be delayed to evaluate, what would be the impact of this? Certainly understand in that section, a lot of those requirements are applying to lots of other human services to add the new background studies requirements. So if that were the case, and if we're to move forward, I think then the other alternative would be, how can we help protect some of these organizations that are employing people that wouldn't otherwise be able to pass a background study, to allow them to continue their work while they're being supervised and working with a recovery community organization.
Vice Chair Gilman.
Thank you, Chair, and thank you for that explanation. And I do believe that folks that are in recovery, that are helping support others that are going through the process, not all their backgrounds are shiny and great. And I'm excited. I've talked with folks locally around this and how challenging it's been for them to find employment and how they're just desiring, with this new lease on life that they have. And we've heard other programs, you know, around different things, how it'd be great if the legislature could do some work around this. And that's something that I would love to help support. And so I'm curious if this recommendation also came from the department, or where this recommendation came from
This was part of the governor's recommendation that we adopted, and also wanted to ask about the set aside when we talk about 245C, especially in background studies. How does that apply to this instance?
Yes.
Director Graham.
Mr. Chair and Representative Gilman, I, for some reason, cannot get the language pulled up on my computer in front of me, but I'm guessing that this has to do with the changes that are required for high-risk providers as they relate to background studies. And if that's accurate, that is a federal requirement, that there's enhanced requirements for background studies for high-risk providers, and those include the fingerprinting aspect. So I'm not sure that we have flexibility, having deemed this as a high-risk service, to be able to modify the background studies here. And Chair Noor, I don't think we have our Office of Inspector General in the room today, so I'll have to get back to you on what the set-aside process is. But I mean, we generally agree with both of you that, and with Mr. Zerbis, that we do have people that are upstanding citizens and have various items on their past, you know, that they may have recovered from and serve a really valuable role in the system. So we're happy to work with you and get you more information to make this workable.
I think I'll go to nonpartisan staff, Ms. Sandeman.
Thank you.
Mr. Chair and members, there is under Section 245C.22, subdivision 4, paragraph E, if an individual is disqualified, receives a disqualification, and the person works in the substance use disorder treatment field, which would be peer recovery support providers, they can request a reconsideration, and this provision requires the commissioner to set aside the disqualification if this 6-item list of criteria are met. So there is a mechanism for a set-aside of a disqualification if it's not a permanent disqualification. But it's things like the individual is not disqualified for a crime of violence, and it lists those crimes. The individual provides documentation of successful completion of treatment, that sort of thing in the list of 6 criteria. So there is a process.
Thank you so much, Ms. Sandeman. That's exactly what I was trying to reference, and not knowing everything in the book, but anyway. So I think this provides us a guidance, but then the question is, if there is any background issues under any of the sections, under that section 5, subdivision 18, then we have to look into the set aside and other instances whereby we can move forward. So at least this helps, but at the same time, I think it's conflicting when we do the background studies, and we'll follow up on this so that we can have more clarity on this section.
Thank you.
Vice Chair Gilman.
Yeah, thanks so much. I do want to have continued conversations around this. Thank you.
Vice Chair Kill, did you want to add anything?
Sure. Thank you, Chair. I want to go back to the first part of your question. So back on 127 with the working group. Not necessarily around the date. I'm interested to see, because this working group has started, correct? Yes, okay. So I talk a lot about working groups and task forces and whatever we want to put together, but making sure that there is a significant Greater Minnesota voice at the table. When I look through the setup of this, and I know we're setting up other work groups in this, and I just want us to be mindful of why I keep saying that. So can somebody tell me, of the people who are listed on here, because the only identifier that says there needs to be an individual from outside the 7-county metro is a representative from county social services agencies. There's no other requirement that any of these individuals have to be from Greater Minnesota. So can you tell me, of this working group and the allocated breakdowns, how many people actually sit on this task force from Greater Minnesota?
Anyone wants to take it? Mr. Zerbis?
I'm not, where are you? Are you on it?
Yeah, Mr. Chair, Representative Keeler, I attend the group as a, I guess, a non-member, non-voting member. I'm not familiar with the breakdown of kind of who's all there and who they represent. I know some of the folks that are on there are from larger organizations that have services throughout Minnesota, but I couldn't answer with specificity kind of what that breakdown is or what the representation is for Greater Minnesota.
Vice Chair.
I mean, can anybody in the room answer that question?
Do I see anyone? I think no one is standing up. Hopefully, we can get that feedback.
So this is the part that gets really infuriating. Over and over and over and over, we talk about having a border-to-border representation in these spaces. And I know I'm like a broken record. Every time we talk about a work group, every time we talk about something, I say we need to have an identifier that requires that some of the individuals at the table are from Greater Minnesota. Because if you look at 2 designees from Department of Health, a commissioner, 2 people with lived experience. We don't know for sure if there's a rural or they're all from the metro. Representatives from 3 substance use disorder lodging facilities. There's no tribal nations. We only list 1 when we know that there's 2 different tribal nations that actually identify in Minnesota. That this is why it's a problem. This is why the words matter when we set up who is a part of these conversations. Because if this is a metro-minded task force, then all the recommendations that come to us are what? Metro-minded. And I appreciate that it's all virtual. I do think that that helps with the geographic spread and people being able to engage. But if nobody's tracking and nobody knows, does that mean that my side of the state, your side of the state isn't represented in the decisions and the recommendations that come back to us? I won't be at this table to continuously yell around about this. And so what I hope is that we get in the habit at this table that we make sure that voices from across the state are a part of all of the decision-making conversations that we have. And so I would like an answer on who shows up for this. And I don't know how we start doing that for all task forces and all working groups, but we need to make sure that this is a standard that we do as we make decisions, because the impacts have a very, very different unintended consequence, ripple effect out to my side of the state and other rural counties. Thank you.
Thank you so much for that. This table will always remember that, because border to border will be critical for all of us. For those who will be here, always remember that. Representative Frederick.
Thank you, Mr. Chair. I just want to go back to the background studies part that we were just discussing, because reading that also raised red flags for me. And then when Mr. Zerbis pointed out that there was a letter that didn't get sent in time, I just reached out to people in the community too about their thoughts on this. And some of the messaging that I just got was that it would be catastrophic for the recovery support services, that the reconsiderations that we just talked about can take 6 months or more, which would make sustaining a workforce impossible. So I can understand that we want to make sure if we're responding to federal action and all of that. But what I think that we have heard in this committee time and time again, we don't want to address something by making it worse, by causing more harm. And that's where this, and I think the comments by Representative Gilman, I think, shiny, that these backgrounds may not be shiny. I think that was the word. That's true. And this process would make it even harder for those individuals, put them in even more precarious place, and then the organizations that are looking to support them, making it harder for them as well. So this section for me is very, very concerning, and I think changes are needed. Thank you.
So Representative Frederick and Vice Chair Gilman, you'll get to work to get us the direction we're going. We've got tomorrow. Yes, all right, appreciate that. Any other question from the members? We have 5 minutes, if anybody's got any question before we which is great. I know we have got more work to do before the markup for tomorrow. Members, make sure that you keep the book that you have before you, because you will need it tomorrow. Vice Chair Gilman.
Okay, I do want to make a comment, and let's talk about this. Is there in statute anywhere that what a working group should look like? Is there like a template? Is there something that we could do collectively to bring forth that would always be boxes that we could get checked to represent the entire state. Has that ever been talked about or introduced in the past? Does any,
We'll go to nonpartisan staff, Ms. Sandeman.
Mr. Chair, Representative Gilman, not to my knowledge, I think working groups tend to be a little less structured than things like task forces. I don't believe there's a template in statute for task forces. There are sort of things we try to include in task forces, but working groups are a little less constricted. But no, there are no templates.
Well, one of the rule is you cannot add legislators when you go to the conference. So if you wanted to add anything
Yeah.
As part of our House rule, I think it has always been a problematic, but there's no guidance or rules in how we create the working group or study. Vice Chair Gilman.
thank you so much. I just think, again, we should think about generations to come. And again, with Vice Keeler not going to be here next year, I do believe that we need to continue to really make sure that we consider all folks across the entire state. And again, I want to go back to my initial frustration is that when we have this working group happening and they've been meeting, I, as a legislator, want to have the information. I've heard from past folks that, people don't read the reports or people don't necessarily take all the information in, but I, as a legislator, feel like it's very vital in order to do the work. This is what we're investing in, our time and energy, and the folks that are meeting. I've been on a working group in the past myself, and it was painful and wonderful. And I learned so many things about infrastructure in our state because of that working group. But again, I also built relationships across the aisle being a part of that. And so in the future, if it's something that other states are doing as they set up, working groups or task force, if it's something that we should look at where people are finding success in other states, I just think we should consider that. So thanks for sharing again.
Thank you. Representative Gunter, you have the last comment or question.
It'll be quick. Thank you, Mr. Chair. I know we're going to take a deeper dive into this the next time we meet, and we're going to hopefully tie it up with a string. I just want to say I don't think we're quite done with family residential services. I hope we can have that conversation again. Thank you.
We have less than, 24 hours to come back and address most of these issues, so hopefully the conversation will keep on going. It's not the end, so we have a lot of iteration process. So hopefully every member will be prepared. Please make sure that House File 4338 information is put in your green jacket so that we can reuse it for tomorrow. Mr. Chair, we will be getting ready for tomorrow. So with that, we are now adjourned. Get to work, everybody. All right, thanks.